Do you have stomach pain? Are you bloated? Do you have bowel pain or reflux or difficulty going to the bathroom? Are you also someone who had endometriosis with or without surgery? Then this is the podcast for you. Learn about all things gut, SIBO, and endometriosis from Dr. Murray Orbuch, a New York City-based gastroenterologist, and the Endometriosis Summit. Welcome to the Endometriosis Summit, the podcast. Joining me today to talk all about bowel and SIBO and everything that goes on with your gut during endometriosis is Dr. Murray Orbuch. Dr. Orbuch, can you introduce yourself?
Yes, thank you, Sally. My name is Dr. Murray Orbuch. I'm an assistant clinical professor of medicine and gastroenterology at the Mount Sinai Medical Center in New York and a clinical attending at the Mount Sinai Hospital in New York. I'm in practice in gastroenterology and have taken a special clinical interest in the GI manifestations of endometriosis.
And what led you to having that special interest in the GI manifestations of endometriosis?
Well, it was kind of a long path. As the years passed, as I completed my training and was in clinical practice, the accumulation of patients who were women with diagnoses of IBS and various abdominal pain syndromes, without a clear explanation, became quite numerous, and it was kind of bearing down on me in terms of trying to find a cause for all this. As chance would have it, my brother, Dr. Lawrence Orbuch, who's now in Los Angeles, had a interest in endometriosis as a endometriosis surgeon and gynecologist. So often patients that would come my way, we would collaborate on patients that came his way. And it became apparent to me that many of the patients diagnosed with irritable bowel syndrome and in fact also inflammatory bowel disease, Crohn's disease or ulcerative colitis, particularly Crohn's disease, were in fact not suffering from those ailments, but that the root cause of these issues were undiagnosed endometriosis. And many of the gastrointestinal manifestations that they've been treated for sometimes a decade or more were in fact wrong, and that in fact endometriosis was underlying many, if not all, of their problems that they were suffering from.
Yeah, when I used to have a clinical practice as a pelvic physical therapist who specialized in endometriosis, I was amazed at the amount of young women you were able to break the cycle of this is IBS for years, like young women that went maybe to the student health center in college and were told you just have a stomach ache, try a diet, try this. You were able to really break that cycle and get them really good endometriosis care. What is something that you would like primaries or gastroenterologists to know about young women or young people assigned female at birth that may be complaining about some stomach aches, but it may be endometriosis and not IBS or any of your inflammatory diseases?
I think it's a failure in education and training that the diagnosis is never entertained. Just like, I remember when I was an intern a very long time ago, I was doing my rotation through the Bellevue Hospital emergency room, and we had the head nurse there was the actual titular head of the ER. And the fascinating thing about her is that she would take all the interns under her wing. She was about 4'9" and one tough lady. And she taught us, the first thing she taught us and reminded us really was that a young woman comes in with abdominal pain. The three things you got to consider are ectopic pregnancy, ectopic pregnancy, ectopic pregnancy. Until you rule out those things, you don't move ahead. The same thing really should apply to GI fellows and pediatricians and internists and family practice docs who are taking care of young women who are just started having their periods or into their teens and come in with symptoms that can be related to IBS. Very often, inflammatory bowel disease was frequently missed, and I see this all the time by people either rushing through things or just not aware of the different disease processes. And they were simply described as irritable bowel syndrome. And so one thing we were always taught as fellows was to never pigeonhole anyone and think outside the box and try to consider all the different the possible differential diagnoses. Endometriosis was not one of those. And it really needs to be something taught to every physician, nurse practitioner, PA, and gastroenterologist who is in training in order to make them aware of this. The incidence of endometriosis in the world depends on the region, but it could be as high as 10%. The solution to endometriosis is not always surgery, and very often it is not. But in order to prevent the progression of the disease over time and its concomitant side effects, such as infertility, dyspareunia, abdominal pain, and IBS symptoms that are often crippling and disabling, you got to recognize early on that this is what might be going on. You got to consider it. If you don't consider it, you'll never find it.
That is so very true. So, what are some of the symptoms that people come to you complaining of stomach pain that may be endometriosis?
Yes. So, very often, particularly with the younger patients, you'll have just simply uh, young women coming in with the complaint of, I have a sensitive stomach. I've always had a sensitive stomach. I get anxious. I get cramps, abdominal pain, diarrhea. I get bloated after eating. I get just unexplained pains. My periods are so bad that I miss days of school each month. I can't spend time with my friends, and particularly with young women who are just becoming sexually active, the complaints of dyspareunia are something that are difficult to get them to admit to. It's often they don't know what they should be expecting, and when the pain appears, they simply don't know what to do with it. One tip-off I found with young women who are not sexually active is inquiring whether they use tampons during their periods. And the interesting finding is you'll find that many of the women who have endometriosis in the rectovaginal septum and have not been sexually active is that they can't insert a tampon because it hurts, so they just never use it, and they don't give a second thought to it, and that's something that they avoid. So it's a matter of asking additional questions in addition to, are you having rectal bleeding? Are you any family history of inflammatory bowel disease or anything of the sort? Is really just adding a few more questions to your history taking, and that may tip you off. Simple as that.
Yeah, I think as a pelvic PT, I used to get a ton of young clients who would come to me, I'm constipated, I'm constipated, I'm constipated. And they would come to a pelvic PT seeking relief. But when you really delve into those questions, which is, are you constipated more with your cycle? Is there pain in specific areas? And you ask the hard questions like, does your constipation prevent you from having sex? Because that may open the door for them to talk about really if there's pain from that. And I happen to work where I had a good GI to refer to, but what do you wish GIs understood about people coming in with all that bloating? We always talk about endo belly. What do you have to say about all that bloating?
Yeah, I mean, again, it's the thank you for mentioning the constipation part, which I didn't mention a moment ago, which is the other coin of the IBS like symptoms, and these are the people who are pigeonholed into IBS-C or IBS mixed, and inquiry is never done deeper, often this sort of default diagnosis of IBS and people walk away is a common finding. The bloating, as you alluded to, is probably multifactorial. If the endometriosis is extensive, it doesn't always have to be extensive, but if it's extensive and there's a lot of scarring in the gut, you have impairment of the normal motility, normal motion of the rectum that is required in defecating. Often there's an associated pelvic floor dysfunction. There can develop anorectal dyssynergy, which impairs the individual's ability to move their bowels on a day-to-day basis. And so you'll see a decline in frequency and effectiveness of bowel movements. Again, the problem with the abdomen and the abdominal exam and people's history really relates to the way the nervous system wires the gut for pain. Very often it is not precise in terms of localizing where the discomfort is. The discomfort can be very, very generalized, particularly with endometriosis, where the implants can be throughout the pelvis and the abdomen. It's a highly inflammatory condition. And so in all likelihood, it's not been very, very well studied, in all likelihood, this chronic underlying abdominal inflammation may perhaps impair the gut's normal motility. So the gut is not a static thing. So the small bowel will have waves that stripping waves that will clear out the contents of the small bowel into the colon. The function of the gut people don't realize. Whereas the stomach's job is to mechanically crush food, small intestine's job is to take the very tiny particles in the presence of enzymes that are then excreted into the gut to break down the foods that you're eating into its constituent tiny compounds that make up these larger molecules of carbohydrates, starch, and proteins, and then absorb them into the gut. What remains at the end of the small intestine, what exits the small intestine is 6-7 meters long, is simply water, the dietary fiber that hasn't been able to break down, and bacteria. So if the small bowel is not propelling things forward and clearing itself out very much, bacteria will linger. And these bacteria very often are fermenters. So in their life cycle, they will simply start breaking down nutrients that should be meant for the consumer rather than the bacteria. And in their life cycle, will start giving off methane and hydrogen in addition to other gases, depending on what they're breaking down. And that results in this extensive bloating, gas, and distension. The gas has nowhere to go but up or down. And very often it stays static and the individual has a difficult time mobilizing it, and they feel absolutely miserable and distended and bloated for constantly for days and weeks on end.
Constantly. And how long does it take someone to finally make it to you and be taken seriously about that bloating and constipation and get the referral that they need? How long do you think that takes?
It's kind of shocking. If just my anecdotal experience, it could be several gynecologists and gastroenterologists, sometimes up to 7 or 8 of each before someone, for that becomes aware. And the fault again doesn't lie with the individual physicians as being lax or sloppy. It simply is just that the awareness is not out there for the healthcare providers, physicians, NPs, PAs to consider that as a diagnosis, and that's really the biggest problem. Very often, patients have made the diagnosis themselves. They're at wit's end, or they have a friend they've heard of that had the diagnosis of endometriosis, went to surgery, and then it occurs to them they have the exact same symptoms.
Yeah, it's very important that education to physicians and also practitioners. And so that's one of the things with the Endometriosis Summit that we wanted to do that was different. We wanted patients and doctors to be on even footing so that everybody could educate each other. But beginning in 2021, we started a third day that was for physicians to educate other practitioners and doctors in the field, because who else better to talk about endometriosis than those that work in endometriosis? So, and our hope is that now we're gonna be in a facility that comes with the CEUs for nurses and PAs, because we all know when your stomach hurts and you go to the primary, the first person you see is either the nurse practitioner or the PA. I wonder, so that cycle of the methane and the gas, and does that have a name with the
Uh,
fermentation?
no, it's really it's an overgrowth. So it's small intestinal bacterial overgrowth, and this fermentation process is a common thing. The gut, the colon included, is critically involved in the generation of critical vitamins and nutrients, and very often they only are created by bacterial action. So, like everything else in the human body or in the body of any living creature, is the yin and the yang of of creation, of balance. And when you lose that balance, very often is when trouble sets in. So, in the case of women with endometriosis or people with endometriosis, is that in all likelihood the motility, the clearance of the contents of the gut is disordered because of the underlying endometriosis.
And do you feel that the adhesions and or the delay of diagnosis contributes to the presence of the what I call SIBO? You're not quite going that far, but do you think the delay of diagnosis and adhesions themselves contribute to that?
Absolutely, it's as again you alluded to, it's a multifactorial thing. So the longer you remain undiagnosed, and the longer that these implants are continually stimulated throughout the year, and as they recede after they're hormonally stimulated, uh, the adhesions develop, and they can be absolutely frightful, to the point where in some cases I've seen simply locked pelvises, and so the entire pelvis is socked in with scar tissue, adhesions, and again, in order to clear contents out, the exit from the human body, the rectum needs to go through mechanical steps to straighten itself out in order for you to allow you to go to move your bowels. And when all the contents of the human pelvis, particularly the female pelvis, has so many structures in it that come together in a very small space, these adhesions will bind disparate structures to each other, can encase the ureters, and a woman comes in with multiple bouts of urinary tract infections or pyelonephritis, kidney infections. The bladder can't empty properly because the urethra is encased. As we mentioned before, sexual dysfunction because of dyspareunia, because the septum that separates the rectum and the vagina can be socked in with scar tissue, and any torsion or any movement of the vagina pulls on the structures that it happens to be connected to by scar tissue. So the scar tissue not only probably also contributes to an impaired normal motility through the gastrointestinal tract, it will be a great factor in the dysfunction of other organs and pelvic pain as well.
Do you feel that just having a surgery or just getting rid of the endometriosis is enough for everyone with bowel issues to restore their function 100%?
Yeah, that's the misimpression. The surgery is not the end. The surgery is really the beginning of the process of resolving the issue. Because of the inflammation, the nervous system is essentially hyped up in a way very much akin to irritable bowel syndrome, where you are hypersensitive to stimulus. You feel things that other people probably wouldn't. Motion of gas through the bowel, pain, discomfort. So you have other things going on that go well beyond simply the mechanical removal of the endometrial implants, which we can get to, which is another problem in terms of the philosophy of the way surgeons address it. And so once the implants, if the surgery, the excisional surgery is complete, no matter how complete it is, you still remain very often with issues of a weak pelvic floor, of anorectal dyssynergy, where your body has now unlearned the things that learned when you were 2.5 years old, to go to the bathroom, and you have to really be retaught how to properly move things, and you have to also there are other adjacent structures that may become dysfunctional. Like one particular problem is the puborectalis muscle. It's a sling muscle that goes from the pubic bone around the bottom of the rectum that needs to relax when you move your bowels. At times it can become hypertrophic, and at times it can become hypertrophic and also paradoxically contract when it's supposed to relax. And so it's essentially not functioning. It's an outlet dysfunction. So that's another one of these conditions that we see that needs to be carefully evaluated by modalities like a plain physical exam can actually tell whether there's something wrong with that. Anorectal manometry, which is another underutilized modality. And another one, which is again underutilized only because of the cost, is an MR defecography, which is an unbelievably excellent study, which tells us a dynamic study, which tells us a lot of what is going wrong when it does. And so using a pelvic floor PT to help matters, but in a directed fashion. So they're not simply generically treating some presumed abnormality, but telling the PT, you have pelvic floor dysfunction that we're dealing with, or you have anorectal dyssynergy that we're treating with Botox injection to the puborectalis muscle that allow it to relax, is really key. Some other modalities which are, gaining appreciation, but remain still a little bit controversial, are trigger point injections to reduce the pain that people experience. And the pain can be pretty crippling, and it may take a while, using SSRIs to downregulate, to change the threshold where pain or discomfort is sensed. There's another addendum to the physical therapy. So it really is a multi-specialty, multidisciplinary approach to the patient after surgery.
And are there ways to approach that intestinal overgrowth from a GI perspective in terms of either diet or pharmaceuticals? And what would be the testing someone would need before that?
So the dietary approach is probably the easiest and quickest to affect an immediate change without having to resort to pharmacologic therapy or other agents. And the food items that tend to be the most offensive are cruciferous vegetables, which again will have complex carbohydrates that are fermented and provide substrate to the bacteria that's overgrown. Beans, legumes, lentils, oatmeal is particularly bad. It's got soluble fiber that the bacteria love to munch on in the gut. And some people will complain with garlic, some with onions, some with peppers, and you have to really, if you again spend the time asking them what bothers them, they'll tell you. And it's the old saw where the old man goes to the doctor, and the doctor says, he goes to the doctor, it hurts when I do this, doc. So the doctor goes, just don't do that. So if you can identify the foods that may provide substantial relief, an elimination diet by going to an elemental diet and then slowly adding small things on may be the best at identifying the offending food items. The diagnostic test, the lactulose or glucose hydrogen breath test, if done properly by people who are actually calibrating the machines and taking the time, can offer a tremendous answer when none has been had for years of the presence of bacterial overgrowth. And just to familiarize people, so you will drink either glucose or lactulose. Lactulose is an alcohol sugar. And the machine will, you blow into a machine every 20 minutes or half hour, depending on how they do it, for something like 90 minutes, 120, 160, sometimes a little longer, to determine whether in fact there's overgrowth. So when you provide the gut with the substrate, within a certain amount of time, when the glucose or lactulose hits the small bowel, the bacteria will begin fermenting it. And so you're simply measuring hydrogen and methane at baseline and hydrogen and methane at certain points along the timeline after the administration of the substrate.
Do you always order the test for SIBO, or do you feel that if it looks like a duck and quacks like a duck, it is a duck and it's time to have the patient do some of the interventions they can do and some of the interventions you can do?
Yeah, often it's really it's the comfort of the patients. Very often with SIBO, that is associated with SIBO that's associated with IBS-like symptoms, IBS-D-like symptoms. It's typically hydrogen overgrowth, and so the patient is comfortable with being treated with an agent like Xifaxan, which is its generic name is rifaximin, and it's a non-absorbed antibiotic. Then I will administer it to them. If the test is available, and very often the SIBO breath test is not immediately available in every place. Even in New York, the number of people that I can send them to that will accept insurances and such are limited. So you have to have your crew of people who do the test in the office that it can get done. In instances that you mentioned that with constipation that may be secondary to endometriosis, very often those cases are more associated with an overgrowth of methane as well, either alone or in combination with hydrogen. And we often treat them with a different pair of antibiotics, rifaximin and neomycin. There are other antibiotics that we use which are absorbed, which are probably reasonably effective, but they have their own side effects because they are absorbed systemically. To have a thorough, clean understanding of what's going on, I prefer to do the breath test. If the patient is uncomfortable and you cannot get it quickly, then and the patient is comfortable with getting the antibiotics, and you're able to get it through the insurance company, there's really no downside at trying it because, again, they're not absorbed.
Right. Many times the test is not covered by insurance. And by the time someone with endometriosis gets to the point where they can have the breath test, they've spent a lot of their money on care already. So
Yeah.
a lot of patients do opt to try the antibiotics because they don't have that such side effects as trying it for no reason. I wonder, how common is reflux in the endometriosis population, but also in this SIBO crowd as well?
Well, it's some of these upper GI symptoms are relatively vague because you'll have abdominal bloating, distension. Again, it needs to be studied better, but if inflammation may be the putative cause of some of the delayed motility of the small bowel, it's utterly and completely conceivable that it may affect the stomach as well. The GERD symptoms I see intermittently, but there's so much overlap. The reflux symptoms are so common in general, so I can't tell whether it's due to it's there anyway or it's due to the endometriosis. So I can't say that I have a strong impression one way or the other.
I see the GERD every day as a practitioner, and I sort of look at it in that way that if the SIBO is creating a methane or another or a hydrogen gas inside the belly, then if it's not, it puts pressure on the esophagus. Now that's not a research thing, but pretty much the majority of my patients who have untreated and undiagnosed SIBO have really bad reflux post excision. Prior to excision, there's lots of other reasons, but I also see reflux for the same reason with pelvic floor dysfunction.
Yeah.
If the outlet's not opening, everything's going to go somewhere.
Yeah, and also it may hint at a more global delay, more global aberration of gut motility. And so again, realizing that the gut begins with the pharynx and goes all the way down to the rectum and the anus, you got a lot of territory to cover, and they're all innervated continuously from one end to the next. And so what affects one part may very well affect another part. So it's very likely that there's some factor that there's some common factor causing these issues.
It's so fascinating. I wonder, is it chronic, or do you treat SIBO once and then it goes away?
Sadly enough, if the underlying issue does not go away, in other words, the aberration in the normal gut motility, it can often recur. So dietary mindfulness, avoiding fermentables, is really the wiser things. And if someone is already lactose intolerant or has some degree of fructose malabsorption, there may be issue with overgrowth on that basis alone. It's dietary. So you have to really make them aware of all the possibilities and try to limit these exacerbating factors. And so, interestingly enough, there's an agent called prucalopride, which is marketed as Motegrity for chronic constipation, different than the other two agents that we have now, Trulance and Linzess, in that it enhances the motility of the colon. So again, a good subject for some future study to see whether that particular agent in individuals who, for example, have a chronic constipation and endometriosis, who've been excised, whose nominal GI function pelvic floor is okay or reasonably okay, whether that will reduce the SIBO symptoms, because it enhances the clearance of things from the GI tract. So, because that agent may in fact also affect the stomach in a positive way. So it remains to be studied.
Yeah, it would be fascinating with the crowd that has some bowel adhesions to see what something like that would do.
Yeah,
That's a little, yeah.
right. But the release, but those medications are often contraindicated in adhesions because it actually can result in obstruction. So relieving those adhesions become really, really critical. And so a good endosurgeon, sadly enough, if there are 100 or 150 throughout the United States, I would probably be overstating the case, will spend hours teasing apart adhesions, searching very carefully for every tiny little implant that they can visualize by whatever means they can try to make them become more apparent, and really just setting straight the contents of the abdominal cavity where they ought to be and not in a distorted fashion. A good hint of how crazy things can get. I mean, the distortions that I've seen on imaging of the uterus and the fallopian tubes and the ovaries in someone who has advanced endometriosis, it's crazy. I mean, you have ovaries in places that they shouldn't be, fallopian tubes in places that they ought not to be. The uterus is completely out of place. So there's a lot of work to do when you actually go into the surgery, and it's underappreciated by the insurance companies, who would love to punt it down the line and pretend it's not a problem, and very often either underpays the price of the surgery. We're not here talking about the cost of stuff, but in order to get people involved in doing this surgery, there has to be some sort of appreciation of how much time it takes. And so when insurance companies think it's a little bit of a joke and don't take seriously the pain, suffering, the effect on a woman's day-to-day life and her fertility, her sexual health, and ultimately her psychological well-being, nothing changes. And they're unfortunately a tremendous obstacle in addition to the awareness of the disease.
Right. So this Dr. Orbuch has to join us at our big conference for 2022, but we always have an entire panel on really like trying to come to a consensus about how we can move endometriosis forward. Because if we wait for the insurance companies to get a standard of care, say from a national organizing body like ACOG, it may never happen. So there's lots of things that need to happen. I wonder, just shifting back to the bowel, are there things that you advise? Usually GIs don't do this, but are there herbs or anything that you advise people take to sort of hold their SIBO at bay, or you really encourage lifestyle changes more?
Well, thanks for raising that particular thing, because it's been an issue. That there are some small studies that have suggested that some of the herbal antibacterials may have benefit in suppressing the regrowth of repopulation of the fermenting bacteria. I've used them with mixed results. I can't say that I've had uniform benefit. In some patients, they will hold off the need for antibiotics by many months. And very often within a year or so, you'll have a recurrence of the SIBO symptoms. and they may have a place in um, just controlling the regrowth of these bacteria. But again, I think that there are other factors involved. The intrinsic bowel motility, the ability for it to clear out bacteria effectively and on a regular basis, that may be more instrumental at preventing the recurrence of symptoms. But I think there's a place for the herbals. You got to try them to see if they work. There's generally no downside. Some people will complain of some GI upset, but for the most part, they either work or they don't. But they're worth a shot because you're avoiding another course of antibiotics that can be expensive. And again, our friendly insurance companies have issues with Xifaxan, rifaximin, because it is not inexpensive, but a lot of them refuse to cover it. Several insurance plans in New York, where I practice, that adamantly refuse to have it on their formulary. And other ones require you to jump through hoops in order to prescribe it. So if you're a physician listening, you got to use a good pharmacy that will work with you to pre-authorize it, because sometimes it's a struggle.
Right. It is certainly a struggle. My particular insurance only likes to do, like, I get a certain amount per lifetime. And so for every time I don't know why the surgery triggers the SIBO, but every time I've ever had surgery, I've needed to do 4 to 6 weeks of the antibiotic. And then I use the herbal regimen to hold it at bay unless I eat something that has cauliflower or chickpeas in it. So there's no cauliflower rice or hummus in my life. And then it's gone. And I think a lot of times with an elimination diet, it's not about here's a list of 47 foods that you can't ever have again, because that leads to some eating disordered behavior, but it's about finding the one trigger. Unfortunately, the other trigger, our favorite fermented food, happens to be wine. So tequila only for me. Do you, yeah, tequila only. So I wonder, do people come to you and they've just spent years trying diets and they don't understand it's endometriosis or something else?
Yeah, I mean, they're often, honestly, when I see them, they are often at wit's end, which is really horrific to see someone who's in their 20s at wit's end, and someone who's in their 30s at double wit's end, and it's painful to watch because it's really affected their personal and professional lives and limited them. And so, it's again going back to the beginning of the awareness of medical providers of the problem. I also want to just go back a step. The manufacturer of I just wanted to shout out to Salix that makes that markets rifaximin, Xifaxan in North America. In my experience, they've been unbelievably supportive in instances where the insurance company is just being recalcitrant and resistant, despite objective evidence of SIBO on the breath test. They have been always kind to help with either the approval process or providing samples to patients for whom I cannot get anything from the insurance companies. So that's really been a help. There are some Canadian pharmacies that are able to get them for patients as well. So one should not fret that the insurance, their plan doesn't cover it. There are ways around it, and I recommend that you either reach out to Salix on their website for patient assistance, or search out the Canadian pharmacy that you can get it. Your physician can work with you.
Right. I've had a patient who has reached out and to the drug company and either gotten samples like you described, or they used to give a coupon so that it became affordable to get, very much like there was a nasal anti-inflammatory we used to use that no insurance company would cover, and the company also issued. So there are some, we talk about lots of things pharma doesn't do great for endometriosis, but there are some really great companies out there looking to serve and help adjunct care. Because we have a little bit of that fertility component to the endometriosis summit, because we work with Dr. Vidali, I see a lot of 40-year-olds who don't realize how involved their bowel pain has been in there. Oh, my stomach, I've always had a sensitive stomach. It doesn't mean that that can't be why I'm not getting pregnant. How often as a GI do you see that side of things? Or are they just done by 40 going and seeking help?
No, I mean it's a recurrent thing that you notice. The I've had I've had a few women who come in who are just having, the usual typical exacerbation of either the constipation, which never goes away, the pain, the bloating, the IBS symptoms. They've had 5 upper endoscopies and 12 colonoscopies, and each time they've shown nothing. And why someone repeats the same thing expecting a different outcome remains to me unclear. It violates Einstein's adage of repeating the same experiment over and over again, expecting a different outcome. So I've had more than a few women come in almost toward the end of their 30s, where just an incidental question on my part about their ability to bear children will get me a surprise answer. Yes, I've gone to some infertility docs; they couldn't do anything, or I just gave up, and I tried IVF, and it was not explored enough. Places like, for example, there's some fertility centers in larger cities that are affiliated with university medical centers, and I have to say that the docs there are much more tuned to the problem of endometriosis. If a woman is 30 something or other and has been evaluated for infertility, if you haven't entertained endometriosis early on, among the first things that you're considering, you haven't done your job. And in my experience in a large center with really phenomenal medical centers, is that it's less the case, and it's become less of a problem over time. But I have in the past on a regular basis seen women coming in their late 30s, and it's never been entertained. You quickly send them to surgery, and there was another anecdote. I had a woman coming in. She was like in her 36, 37, chronic IBS symptoms. She just moved to New York from some smaller city, and asking her the questions, it became obvious to me that she very likely had endometriosis. Sent her off to an endosurgeon who immediately did excisional surgery. And then he calls me up a year later because the woman showed up back post-op for her post-op check, and then came back a year later for follow-up, and she was 4 months pregnant. It was the first time she was able to conceive in all her adult life, and it was clearly due to that. So, an endosurgeon's a good one. Their greatest joy is simply having a collection of pictures of small babies that they were instrumental in allowing to happen. It's a wonderful thing.
Yeah, it's a wonderful thing. We talk a lot with the Endometriosis Summit about the quality of life side of things. But I think when it comes to fertility, a lot of people don't make that connection that their stomach aches are part of their infertility.
Well, this is part of changing the mindset. I mean, I've had my own run-ins with insurance companies and institutions about this, and why this is being pursued when someone is 19 or 20. If you don't fix it when they're 19 or 20, you'll end up with a woman in her late 30s who's been unable to conceive, in addition to having a rather limited quality of life because of the condition.
Yeah. And that's what ultimately all of us that participate here are trying to prevent, that you've given a career and research to trying to prevent that. And so have we. So as we begin to wrap up, I wonder if you could give us 3 action statements that you want people to know about the gut and endometriosis and enabling their care to be better.
I think it's because of the awareness that's only growing now among health professionals regarding endometriosis. It becomes important that young women, in particular, because that's one that really presents, are aware of what may be going on, and it needs to be something that's taught in high school when they're teaching biology or teaching health and that sort of thing, wellness to kids. And then don't sit and suffer for years, and don't let someone tell you that you're crazy or just blow you off. That's going on. That nothing is going on. Something's clearly going on. You're not well. And you got to go to someone who knows how to sort it through. And don't take no for an answer if they have given you no reasonable solution to the problem. And that's really, you have to self-advocate. It's really the bottom line.
Yes, that is so very true. Before we wrap up, Dr. Orbuch, how can people reach you and get in touch with you so you can do
Oh, thank
more
you.
podcasts?
Oh, sure. I have my practice has a website. It's murrayorbachmd.com, murrayorbachmd.com. I practice in Manhattan. My office is located in 2 locations in Manhattan. Our general number is 212-688-0813. My email address is m.orbuchmd@gmail.com. And happy to see if I can be of assistance and direct you to my colleagues who are likewise aware of what's going on.
We were so happy to have you here today. I wonder, are you still doing telehealth, or telehealth has ended for you?
It's starting to wane as people are less frightened of going outdoors, which is a wonderful thing to see, because particularly in Manhattan, life was moribund and gone for months at a time. But people are beginning to hop out as their vaccination rates exceed 70 or 80% in certain populations, which is wonderful to see.
Yeah, it's great to see. Where I was pretty much open the whole time. So, but then when I came back to New Jersey to watch it open, it was just great. Thank you so much for joining us. I hope you will join us the first weekend in March. We'll put something together so that we can talk about gut to this extent. And I look forward to everybody contacting you and to continuing the discussion on bowel and endometriosis.
Thank you very much for giving me the opportunity to chat about this. And I laud you for this really rather important effort to reach out to so many people who have gone unaddressed with their real serious issues. And so I have to thank you as well.
Awesome.